us, and I want to thank you very much for joining us.
My pleasure.
You're with Pacifica Health.
Yeah, Pacifica Medicine and Wellness with Dr. Andrea Chaimi.
Uh-huh.
Who I think
And Andrea was going to join us today, but she's been caught up, and so graciously you're going to drop in and help us understand a little bit about what's going on with the novel coronavirus here in our neck of the woods, Kitsap County, and so forth.
Absolutely, my pleasure. Yes. Did you guys have some questions to start,
Well,
or?
yeah, I would just like you to tell us a little bit about. I see that we've over the last few weeks we've been obviously trying to retard the transportation of the virus in our community, but we continue obviously to see positive cases go up from the Kitsap Public Health Department. So I'm just wondering if you can tell us a little bit about, from the medical perspective, where we are. Does it look like we're on a similar, at least, trajectory in terms of wave as Seattle? Are we keeping track with trying to maybe get a handle on the transmission of this virus?
Yes, my pleasure. I would say that we are in excellent shape. Washington has made tremendous progress with flattening the curve. As you look at our data as a state, there's several different websites. I'm sure you guys are going on the same ones I am, from the Department of Health, the CDC. The University of Washington has a great map with resources based on state level. The John Hopkins, there's also one called Worldometer that measures all these different parameters. And while we are still seeing increased number of cases, the rate of increase has slowed, and it looks like we're starting to see a decrease in the percentage of cases coming in. So it looks like our moves to self-quarantine are helping to flatten the curve, so to speak, as we've heard everybody talking about. So we do see cases increasing. Right now, there are 102 in Kitsap County, no deaths. The hospitals are in excellent shape to take care of people. In fact, we're not looking to have any shortages of hospital beds, nor of ICU beds, nor of ventilators, and we have a surplus. So we're actually shipping our ventilators now to New York, the excess that we see. Based on the way our numbers look, they project the peak of where we think the cases are going to be. For Washington State at this point, it looks like our peak was hit of resource use even a couple days ago. So we look to be.
What you say, the peak of resources. So you're talking about the greatest risk of pressure on medical facilities and hospitals.
Exactly. Yeah. So the resource use, meaning the medical system, and in our ability to take care of patients suffering from complications of the coronavirus. So I feel like here in Washington, and especially Kitsap, we can feel really confident in our ability to help take care of folks when they need the care. If things continue the way that they are, then we aren't in the same position as some of the big hot spots, the big cities like New York City, New Orleans, Washington, D.C., the other communities that we see that are really maxing out their hospital resources.
Okay, we're talking to Dr. Marie Matty, and she's works out of Paulsbo. She's a Bainbridge Island resident, and we really thank you for joining us today. You're with Pacifica Medicine, and yes. If people have questions, I would invite you to either make a note on the chat, and I'll call on you, or like Janet just did, she sort of waved her hand.
Wonderful, Janet. Hello.
Please, can I ask a question? My son got tested for coronavirus, and happily he didn't have it, but it took 9 days for the results to come back. Is that still happen to be the case? And because Bainbridge Island seems to have a very small number of cases at 10. But
10, yes, ma'am.
For the last week. So is there still a lag in testing?
That lag that you're describing, we did see that. That lag took place 2 weeks ago. And what happened was almost all of the clinics are using LabCorp as their facility to run the lab tests. And they became completely backed up with the backlog sending their tests over to North Carolina. So they opened up a new lab down in Arizona. And we found that while we were in that leg of waiting 9, even 10 days for results, we were getting results back within 2 days that were sent afterwards to Arizona.
Okay,
and
good.
now we're seeing all the tests come back within 48 hours. So
Thank
things
you.
have they've been able to dramatically improve that, because that is extremely unsettling, upsetting, the waiting game, the self-isolation that we recommend when people are waiting for their tests. But we've made tremendous progress. And, you know, as a segue, we do expect in the next month to be able to do the antibody test on the blood specimen, which should be able to get us results within 15 minutes to 45,
good.
depending. Yeah. So hopefully that's just a matter of getting those tests moved out to the bigger clinics and hospitals. But that will be probably within the next month, we'll start to see that.
So, Dr. Matty, can you talk a little bit about the advantage of that antibody test?
Yeah, the advantage is, one, of course, our speed, because we get it back immediately. That's one of the biggest advantages. The other is, while it's a finger poke and getting a blood sample, that's uncomfortable, but not the nasal swab that people feel like you're touching their eyeballs, which cause a lot more coughing, sputtering. So as far as risk to healthcare providers, it will be less risk also for administering the test. Additionally, it'll allow us to better assess who the asymptomatic people have been that have had the illness. The downside is that for the test to be positive, you have to have had the virus for a week for the initial immediate response antibodies to show up. So there's 2 antibodies that they test for: the IgM, which takes a week to start to show, that's your first immunity, and then the IgG, which takes 2 weeks. So the downside is that it won't be something that you can get some false negatives if you test it too quickly, but it'll also give us an idea of who's immune, who could go back out to the community, get back into work, get back into working or going to places like the senior center, working safely in the hospitals. So it's going to be a good thing to have available.
So you said that we're doing a good job of social distancing, of physically distancing from each other. It looks like we've done it. We're keeping the virus from transmitting any faster than we can. I mean, obviously, there's always a risk, and with the asymptomatic carriers, we don't know who we might come in contact with that might help transmit the virus. So what kind of a timeline? I've heard everything from, obviously, the governor is talking about slowly getting back in May, to reports from Bill Gates about as many as 10 weeks. What do we have any idea really at this point how patient we're going to have to be?
That is probably one of the biggest questions everybody has. And I really, really wish and would hope that our people in positions of authority and government would be better able to give us some ideas of what they're forecasting and seeing. What we do know is that there are some parameters we're looking for. The parameters we're looking for is an increased ability to test. And that is something that's constantly being evaluated, both for the viral swabs that we have available to us now, as well as the antibody tests that should be increasingly available. We need to have that decreased trend that we're starting to see flatten out now happen for at least 2 weeks. So after we start to see that for 2 weeks, we have increased available of testing. We have the Department of Health set up and ready to do tracking and testing to make sure that the people that are found to be at increased risk or have the virus can be self-quarantined and contained, and then to make sure that our hospitals continue to be in the excellent shape that they are, which everything's pointing to that direction. My concern is if we do it too soon, then we'll have a spike and we'll end up going back into the same position. So, I hear the same thing, everything from May to June to potentially August. And until we get a little bit more data, we don't know, but it would certainly be nice to have those guidelines. And I think we're starting to see more of those coming out kind of sporadically and by different organizations. But I would say by May, over the next 2 to 4 weeks, we'll have a much better idea of what to expect. So we just have to hold tight to get a few more data points.
And for those of us, Dr. Matty, who are in the older sector of the population, I'm guessing that probably we can expect that there'll be some sort of a slow movement towards reactivation, not, everybody show up at the
Senior center, like, yeah.
Yeah, right. Let's all pack in and have a party on May 5th.
Yeah, no, I think that's the kind of guidance I think we'd all like to see, is how we're going to start getting back re-engaged into community activities, and coming up with a plan. And I think that's largely going to be on this antibody test, because if we can determine who's immune, then we're going to know who's safe to go back out. And if we can do that, then, community centers like where you guys are, we can have workers there that we know are immune, that are not going to be asymptomatic carriers. We can get folks that have been exposed and didn't even know that they had it, which we expect to be quite a bit, actually. I think it'll be interesting from an epidemiologic, standpoint to see where those numbers are, but I think we're going to be surprised. But I think it's going to be something that just sort of we get back into community and do it in a little bit different manner, maybe with masks on,
And I'm starting to see some sort of adjustments to that sort of thing. People are going shopping a little less often, and when they're at the grocery or somewhere where they're going to come in contact with people, I'm seeing more people wearing masks, and I'm assuming you'd recommend that kind of behavior.
Yeah, I certainly do. I think there were a lot of reasons. I think it wasn't recommended to wear masks. I'm wearing them at work all day long. Any of us that are in contact with people are wearing them. And it's really to protect others, is the biggest thing. Because if you happen to be an asymptomatic carrier, you don't want to be that vector. We know that works really, really well to prevent the spread of those respiratory droplets. We need more specific masks for protecting getting it. But if we do social distancing, we wear masks, I think we're going to see a huge, tremendous shift in the downward curve down to the incidence of the disease. And as we do that, we're going to feel even more confident re-engaging in the community.
Now, one of the things that is sort of, if anybody has a question, certainly pop up and interrupt me. But one of the things that's kind of not been clear to me is, since we don't have an immunity to this virus, and let's say that we knock it down in terms of spreading through the population, how permanent is that? Is there inevitably going to be a time when we're going to see another resurgence of transmission?
Right. No, I agree. I think most likely there will be, probably, if it behaves, and it's, I don't want to compare it to the flu because it is a totally different virus. But based on the numbers that we have, even if we have it way low into the summertime, as we're more outside and, we've done all the physical distancing measures, when we go back into the fall, I suspect there will be an increase, but we'll also have more community-wide immunity. And what I like to tell people is what we need to have is, we're flattening that curve, but the area under the curve is to remain the same of the number of people that need to have the virus to create that herd immunity or community immunity. And what would be ideal is if we could assess who are the lowest risk people, so that they can carry that immunity until we get a vaccine out, which could be hopefully sooner than later, but certainly a couple of years down the road, to mass produce it. Because it's a bit of an art form to create those vaccines. So yes, I think we'll continue to see it. We want to see it in a way that we can take care of the people that have, the complications. I also saw that there's more and more protocols coming out from doctors across the country and the world to come up with treatment protocols to prevent the complications that lead to the respiratory distress syndrome. So I think there's going to be a tremendous shift in the next few months. And what we're doing now is buying time for all of that to happen. So yes, I think we're going to continue to see it. I'd be really surprised if it went away completely. But I think it's going to be something to treat it. So then we can get back to a more normal life.
Chuck Hodiger had a question here. How many of the 100+ positive cases in the county were eventually hospitalized? And do we know how many are currently hospitalized or recovering? Do you have any idea of how that's going? Dr. Matty, did you hear my question?
Oh, sorry, I didn't hear your question. I thought you were asking somebody else.
Oh, Chuck
Sorry,
was
Chuck
was talking about hospitalization. Do we know how much, how many of the 100+ people who have tested positive ended up in the hospital, roughly, and whether those people are recovering and getting out of the hospital?
You know, what we see across the board is about 15% of the people that get the illness that test positive end up requiring hospital support. And 5% require more ICU heavy, support. And yes, people that, that's the big thing we're trying to do is figure out how to keep people that are in the hospital in the regular hospital beds and out of the ICU. And that's where a lot of these doctors are collaborating and healthcare providers to try to determine what is it that makes that change happen. First of all, what makes people get sick enough to need the hospital, but what makes that shift? And that tends to be immune response. And I think there's a lot of work being done there. But yeah, we are seeing people getting out of the hospital. We've had a couple patients with it here that are recovering. And there's a lag when you look at those numbers. I know when you look on the websites to who has recovered. That part of that leg is that we have the more severe cases being tested because of our lack of testing availability. But yeah, we do see people getting better. I'm hearing things from doctors in the hospitals where they have a lot more in Seattle. And it's a tricky situation because when you end up on a ventilator with this particular illness, it can be weeks on the ventilator. But so we're still in the baby stages of that, but we are seeing people recover for sure.
And this has been a lot in the news, and it's not always clear how much of it is political and how much is medical. But what's your understanding of the lupus and arthritis medicines and what help they might be or when they might be of help for people who get the virus?
Yeah. So you're referring particularly to hydroxychloroquine,
which I was afraid to say.
I know, I don't blame you, which is the brand name Plaquenil. And there's definitely some promising results with that particular combined with the azithromycin, but it's not the typical types of studies that we like to hang our hat on in medicine. They're not double-blind controlled studies. They're small samples. And that's what it's hard for us to really know for sure. And while they're generally considered quite safe, there are some downsides. And I think that there is some good data in vitro, which means they test that against the virus and how it functions in preventing the virus from replicating in a setting, in a test tube, basically, if I was to say it that way, in a lab setting. But we haven't been able to see that done and studied in vivo because of the newness of the virus. And we just aren't, it's hard to do these randomized controlled double-blind studies in a crisis situation. So there's a lot of hope with them, some downsides, and I think we need, again, we're still in those early stages of understanding.
Great.
Also, the other one is the remdesivir, which is an antiretroviral developed for HIV because HIV is an RNA virus like the coronavirus, and it's showing some hope too. The hard part is, as ill-prepared as we were going into the situation, we don't have high quantities of these medications produced. So initially in the medical community, we were talking about using them just for the severe cases, in the hospital, intubated and, with severe pneumonia. And what we suspect is just like with the Tamiflu medicine that we use for influenza, you want to start it as soon as possible upon diagnosis so that you can help, because the idea is to ultimately prevent those complications. So we need to move to that, to trying to administer them earlier, but that would be in a more primary care setting. And that's a more complicated situation when there's shortages everywhere. You can't even get it, practically now in most pharmacies. So it's a tricky situation with both of those medications.
Bill has a question. He says, if I have some symptoms such as coughing and a low-grade temperature, what should I do?
Well, I certainly think that warrants being tested, and we would suggest you contact your physician. And there are places to get tested on the island through Virginia Mason combined with the urgent care there. They've been doing it. We're starting, it's going to come out this week, but we're going to start doing drive-through testing in Bremerton later this week. I'll be there on Friday. That's where Andre Chimey is right now, getting that all set up for Kitsap County. And they're going to announce more details. They still have, it's still in the works. We don't have all the testing access just yet, but that certainly warrants testing. We know it's low grade, temperature often fluctuating up and down. There's such a variable course. That's what's so fascinating. You know, with influenza, when we see influenza coming in the wintertime, we can pretty much identify it just based on the clinical symptoms and then confirm it with a lab evaluation that's immediate. But with this one, there's such a huge variety. But certainly anybody with low-grade fever, cough, and in an increased risk group, being either based on age or chronic medical conditions, it definitely warrants a test.
I have a question
my
from
understanding is-
Richard Herzog.
Well, we do it that way.
Go ahead, Richard.
Thank you. With regards to the masks, the ones have hooks over your ears. Can you use them, and can they be disinfected?
Okay, reuse of masks.
Okay, that was the question.
What do
Sorry,
you know about?
kind of broke up. So my understanding
Yeah.
is the question of, can we reuse masks that go over your ears? And, you know, we've
Right.
been reusing our masks. I've been using the same N95 for a month in the office. We have those disposable surgical masks too. There are a few key features, one of which is when you're removing the mask, you want to always make sure you're removing it from the ear so that you don't touch the mask that could be contaminated. And then placing it down and only touching those ears when you replace it, make sure you're placing it in the proper way. But yes, you can reuse them. For some of those masks that go over the ears, there's even protocols of how to re-sterilize them on a low setting in the oven. I believe, I have to look at that again. If I'm off memory, it's 145 degrees. But that will re-sterilize them. So yes, we absolutely think you should keep using them. And it's ideally, what I think is a great way to do it is one of those, then with a homemade cloth mask over it, which then you can wash. And that will keep it super safe. That's what I'm having. My husband's a pilot, so he's considered an essential worker. So he's using that, so he has the double, so he can wash the one and then have that other one behind it.
And Chuck is asking, what's the criteria for being tested locally? If only about, what did you say, 5% are being tested positive? Do you need to be hospitalized? No, you're saying that basically ask your doctor.
Yep. Because what we're doing is we've been trying to, follow the CDC guidelines, which is cough, shortness of breath, and fever is what we've been instructed to do from a medical perspective, given that we don't have a high access to tests. So, we've been trying to tell people if it's not going to change the course of treatment, we don't necessarily want to test. But if you are, a senior or somebody in a higher risk group that's having low grade fevers and cough, then you meet those criteria based on the CDC guidelines. So pretty much any physician that has access to testing would certainly suggest that you would be somebody who would be tested. Somebody who we may not recommend to be tested would be, say, a young person who doesn't have a fever, they have a cough, a sore throat, runny nose, they have a viral symptom that it's not going to change anything. They're not at high risk. We're going to say, let's hold off and keep those tests for the more high risk people until we have more access and treat it symptomatically like we would any virus. Because it's the same symptom for this versus your run of the mill cold, with rest fluids, Tylenol, Mucinex, antihistamines, nasal steroids, all the same sort of treatment that we do to help our bodies fight it.
This is Chuck.
So the advantage of the testing is really more, oh, go ahead. Go ahead, Chuck.
Okay, I'd asked about Oregon. I hear reports down there that even EMT personnel with colds and, had been exposed to patients every day, even they can't get tested until they have symptoms sufficient enough to end up in the hospital. It just sounds
that seems
incredible.
That seems very unfortunate to me. And we're not in that situation. I can speak to Kitsap County. Andre Chimey and I and Viola Medina is our nurse practitioner here. We are in agreement to test any of our first responders.
Okay, good. Yeah.
And they have access to tests. So they will bring
good.
their own tests if they become symptomatic. So, I mean, you hear those stories. I'm surprised by that because we've set aside those tests for the first responders because they are the first people to go out and contact, and we want to make sure that that they're not spreading the virus. One of the ultimate things, one is make sure they're healthy, but also make sure they're not a vector because they are out in the community.
I just heard this in Portland and Salem being the issue.
They did that. Yeah, that's unsettling to say the least.
And obviously there's a lot of movement right now, and there's a lot of difference from week to week about what kinds of supplies are available. And so a story that you might hear from last week may or may not be true this week, I'm thinking.
Exactly.
Lynn has a question.
Yeah, I actually had these symptoms, very mild, but I had them about 5 weeks ago and called the doctor. And basically they said if I hadn't been around somebody who I knew had either traveled out of the country or had tested positively, to just stay home and take care of it. So which I've done, and I've been fine, although it took the cough 3 weeks to go away. But I would like to know when would it be possible for me to get tested to see if I did have it, so that if I had the antibodies, I could be back out in the community?
That is an excellent question. And that is exactly what we need that test to come out. And hopefully, I'm suspicious that within April, we will have it in our community. Who gets it first? I don't know. Some of the bigger hospital organizations have more weight with getting supplies like that. Certainly will be available in Seattle. I was going to call our local LabCorp today and see if they had any idea of when we could do a sample to check for the antibodies. It's all the reagent, even if we don't have the specific tools that you read about, like the Abbott quick test, they should be able to start running those tests in regular labs as well. But we just need them to be set up and ready to do that. So I think in the next month that you would be able to do that. And I think we're going to find more people had it than we know. And that's part of that learning process, is that now we're learning how many people have very mild cases or have even asymptomatic cases. So that's going to be one of the key things that we need to know, the key pieces of information in order to transition out of this physical distancing quarantine that we're doing right now. And I'm optimistic April will be the month that we'll have that.
Richard Herzog here with another question about the masks.
Yes, sir.
I'm going for surgery tomorrow. And with regards to the paper masks that you get in the hospitals that go over my ears, please be specific and tell me, if I spray it with disinfectant, is that going to be good or not, so that I can reuse it?
I worry that certain disinfectants can compromise the integrity of that mask, because that mask is designed to be disposable. So I'm concerned that wouldn't be good for the functioning of that mask. And those masks offer protection, certainly from catching it, but especially from transmitting it. So I would suggest that instead you follow the protocol that you can see online of how to do it in an oven without actually spraying material on it that could compromise the integrity of that light paper. I think that would be the best thing to do. And just make sure you're washing your hands after you're touching it. And then based on the amount of time this virus can live on certain materials, within a few days, that mask in and of itself would be good again, as far as not having the contagion on it.
Yeah, and Richard, just to let you know,
Yes.
at IBC, we just got in a big batch. We're getting them in constantly, but those coverings. So if you have a surgical mask, you can wear that, but we could give you one of those cloth ones that you could put over it, like she suggested earlier. So we can get one of those to you if you'd like.
And how would I arrange for that? Call IVC?
Yeah, we'll follow up with you. We'll follow up with you after
Thank
this
you.
call. So a question here, I think, about the antibody test. How far back will that test go? How long can we tell? If one had symptoms in January, would a test in April, if we were in a position to do antibody tests, show that I had the antibodies?
It should. That's the follow-up question. We just don't know because the virus has only been around for, less than half a year. So one of the big questions we have is how long does that immunity last? And that immunity meaning those antibodies. And with certain coronavirus, the other coronaviruses can cause the common cold, and we can get those every year. As you know, your immunity wanes. With the SARS virus of 2003, they were able to detect antibodies 2 years after the infection. So yes, it will certainly do it if you had the infection only a couple months ago. But again, we'll have to learn more as we go as to how long we can detect those antibodies and how well those antibodies work. That will be the other question that we won't necessarily have the answer to. But it'll certainly be very reassuring to be able to assess who has the antibodies, who's had the infection, and how that offers protection going forward. But we don't know yet how long those antibodies will stay in our system.
Okay. Are there any other questions? Because I really want to thank you, Dr. Matty, for spending the half hour with us here. You're a physician at Pacifica Medicine in Paulsbo, and you've lived here for a while on Bainbridge, right?
Yeah, 17 years now.
There you go. All right, you're no longer a newcomer.
Thank you.
Thank you, you guys. Take care.
Yeah, thank you very much for joining us.
My pleasure.
And those of you who are on the phone can stick around, and we can talk about this or other things after Dr. Matty goes. But thank you very much again for spending the time with us. We really learned a lot.
Okay, my pleasure, you guys. Take care.
Okay.